Good morning, folks. My name is Lee Wilson, and I am the Director of the Division of Healthy Start and Perinatal Services in the Maternal and Child Health Bureau at the Health Resources and Services Administration. I'm acting as the designated federal official for the opening the Advisory Committee on Infant and Maternal Mortality, the June meeting, which is being held Tuesday, June 14th and Wednesday, June 15th. This is a public meeting. All are welcome. And our advisory committee is convening today to discuss the issues that have been presented and outlined in the Federal Register notice. Just before we begin the meeting, I'd like to make a couple announcements. First, welcome back to Vanessa Lee, the official designated federal official who is returning after parental leave. She will return into her official role as designated federal official following this meeting, but she is here for moral support, good input and wisdom, and we appreciate her return. She's also brought with her a new junior employee named Iris, and we look forward to working with baby Iris as well. Second, I'd like to thank Ann Leach on our staff at the Maternal and Child Health Bureau, who has been working to support the advisory committee in Vanessa's absence. Ann has done a fantastic job of stepping in, learning the ropes, and being just the epitome of support in the development of our agendas, working with Dr. Ellinger and the committee, and making sure that all of these meetings run smoothly and well. Also, thanks to Abigail Deschately, Judy Deschately, who is the core for the logistics contractor and the work that she's done in preparing the minutes for approval. I do want to announce that we have extended committee members who would be expiring in June following this meeting to give them the opportunity to participate in the September meeting, since we have juggled our meetings around. So for those of you who had requested an extension, those extensions have been approved, and I believe you've been contacted by, our ethics officials and by Ann Leach. I also want to acknowledge Jeannie Connery and Paul Wise, who are rolling off the committee after this meeting. I'm not sure that either of them are going to be able to participate in this meeting, but they had committed themselves to many years working on the committee and provided just a wealth of expertise, insight, and wisdom in guiding the direction of the committee on the topics that they've invested themselves in. So thank you officially to them. And finally, I'd just like to welcome all of you to this meeting, and we look forward to your participation and insights on these issues. So let me turn it over now to Ed Ellinger, the chair.
Thank you, Lee, and let me welcome all of you. Good morning to everyone, and I know that our country is experiencing rain and fires and heat, and I hope all of you are safe where you are, and so I'm glad you're with us. And I want to also add my thanks to Ann for all of the work that she's done over the last several months in Vanessa's absence, and really appreciate it, and all of the people at MCHB that has made all of this possible. So all of those people that you mentioned, Lee, I've not worked directly with some of them, but I know indirectly I have worked with all of them, and I really appreciated working with Ann. It's been really, really nice. So could we just kind of go on gallery view and take off the slide? So I want to first acknowledge that here I am, I'm Ed Ellinger, and I'm in Minnesota, the ancestral land of the Dakota and Ojibwe. And it's actually an important day here. I don't know about an important day, but it's a celebratory day, because just yesterday, Owamni, a restaurant in Minneapolis that serves only indigenous foods. It's run by Sean Sherman, who calls himself the Sioux Chef, S-I-O-U-X chef. He won as the best new restaurant in the James Beard Award nationally. So I'm thinking that when you all come to Minnesota in September, we probably have to make reservations now to that restaurant, because I know already they're 3 months booked out. So I think it's really nice that we're acknowledging all of the indigenous folks and the indigenous foods here in Minnesota, and nationally recognized with the James Beard Award. So with that, I sent to all of the ACIMM members, the appointed ACIMM members, an instruction last night about how to introduce themselves. And I give you a little background. There's a planning method called backcasting. I don't know if you know about it, but it starts with defining a desirable future and then works backwards to identify the policies and programs that will connect with each other, that connect the future with the present. And the final or the fundamental question with backcasting is, if you want to attain a certain goal, what actions must be taken to get there? And so that's what I've asked the ACIMM members to do with their introductions, along with their name and title and position. I want them to answer this question: what will it take to? And then they get to fill in the blank of whatever the public health goal and objective is. And it can be expansive or narrow, it can be objective or subjective, visionary or very practical. And they get to do that in less than a minute. Normal backcasting sometimes takes months to do. We're going to do it in a minute. So I'll start out. I'm Ed Ellinger. I'm the former director of maternal and child health at the Minneapolis Health Department and former commissioner of health in Minnesota. So my question is, what will it take for ACIMM to develop a set of powerful, strategic, and impactful recommendations related to the health of First Nations and Indigenous mothers and infants? It will take the involvement, commitment, and prioritization of time of every member of this committee. So with that, that's my introduction. And I will now kind of go down alphabetically. So Sherry Alderman.
Hello, thank you very much. My name is Sherry Alderman. I am located in Portland, Oregon. And what will it take to address the unacceptable disparities in health and well-being of children? And what it will take is for us as a society to realize the rights of children for all children in our country and around the world.
Thank you. Steve Calvin.
Hi, Steve Calvin, Minneapolis, Minnesota. I'm not too far from where Ed is. I'm a maternal fetal medicine specialist who works with midwives at the Minnesota Birth Center. What would it take for kind of a more coherent and responsive maternity and newborn care system? And I'm hoping that to work with ACIMM, which is some of it's already been started and some is, I think, pending in the future, how we can develop team-based care models that include physicians, midwives, doulas, community health workers, nurses, and all those concerned to provide care in a way that meets the needs of both the urban population and the rural population.
All right, thank you. Next on my list is Charlene Collier. I know she's coming, she might get here a little bit late. She's coming from another meeting. And Jeannie Conry is, as Lee said, is not on the committee anymore or is going off. Tara Sander Lee cannot make it today, but she will be here tomorrow. And Colleen Malloy will be in and out for most of today. So I don't think Colleen is on right now. I don't see her name. So then Catherine Menard, Kate Menard.
Well, good morning, everybody. What will it take? What will it take to ensure that every pregnant and postpartum person can assess high quality, holistic, and well-coordinated care that's appropriate and tailored to her medical, cultural needs and preferences? What that would look like would be that every individual that has uncomplicated pregnancies can receive comprehensive quality care delivered in and by their community. Those at high risk for complications due to medical and obstetric conditions receive well-coordinated multidisciplinary care that they deserve in a location or facility that's prepared to meet their needs and those of the babies. What we need to do to accomplish that is have our clinical colleagues, our public health colleagues, and our policymakers, including payers, work in collaboration toward that end.
Great, thank you, Kate. Joy Nyhart.
Good morning. I am a primary care pediatrician working with the Southeast Alaska Regional Health Consortium, which is a tribal health organization in Southeast Alaska. I was recently employed by them, and I'm working with them as a primary care pediatrician and also helping to develop their new service line, which is primary care pediatrics. Previously, they were just a family health dominated or a family health organization. In any case, my question is, what will it take to reduce poor outcomes for all families? And poor outcomes including mortality, school failure, substance misuse, poverty, incarceration, domestic violence, and suicide can be reduced by using the evidence we already have to appropriate funding for services for pregnant people in early childhood. We know that for every dollar spent, 6 to 10 are saved. And so if we could do that, we would improve lives for all kids and all families. Thank you.
Thanks, Joy. Janelle Palacios.
Hi, I'm speaking to you from ancestral Pomo and Miwok lands in Northern California. And I just want to say that I love how Ed stated we could give something practical or visionary. So I'm going to give you something visionary. I'm Janelle Palacios. I am Salish and Kootenai. I'm from the Flathead Indian Reservation in northwestern Montana. I currently live in Northern California, and I practice as a nurse midwife, researcher, and consultant. What will it take to improve the health and well-being of all people in our nation? It will take us seeing each other not as other, but as neighbors, as family, as friends, as humans. I believe a good step forward meeting this goal is to start with history and for our nation to address its history to promote healing, understanding that will in fact change policies and general kindness to all fellow humans.
Excellent. Magda, I don't see Magda's name on the list, so maybe she's not signed in yet. And Belinda, I know, is going to be a little bit late today. Marie Elizabeth Ramos. Is Marie on? Don't see her name. And Phyllis is not going to be with us. She's in Michigan on it, doing some other speaking. Sharonda. I don't see Sharonda's name. Jacob Warren.
Hey everybody, my name is Jacob Warren. I'm a health equity epidemiologist, and for the next 2 weeks, I'm the endowed chair and director of the Center for Rural Health and Health Disparities in the Mercer University School of Medicine. But as of June 30th, I will be the Dean of the College of Health Sciences at the University of Wyoming, thus the new background. So I actually apologize in advance. I'll be in and out of the meeting over the next couple of days because there's a lot going on at the moment, getting ready to go from Georgia to Wyoming in 2 weeks. So my question was, what will it take to make sure that all people can receive quality, accessible prenatal care? I'm going to take a page out of Janelle's book and hopefully take it up a step to be a little more visionary, because I think that's a pretty big question. But to me, I think the answer there is really having to find ways to work across all ideologies and all perspectives to find our common thread of humanity in recognizing that access to prenatal care is a human right. And I think once we start to frame it that way, we can hopefully start to find some paths forward.
Thank you, Jacob. And I hope you can stick around as much as you can.
Thank you.
And Paul Weiss, again, will be in and out of the meeting. He has been called on to McAllen, Texas to do some work there, but he texted me last night saying he's really interested in the agenda that we have, because a lot of it relates also to what's happening on the border. So he will be in and out. Are there any appointed SACIMM members that are here that I didn't call on? I see now Dr. Peck is now on. So Magda, if you could introduce yourself and answer the question that I posed last night. Yep, you're on mute.
Try again. Is my audio clear? Having a little technical difficulties when you work from anywhere in the country. Sometimes you have to adapt. So thank you, colleagues. My apologies for being late today. And allow me to give you my my introduction in just a second, which is prepared. So, well, first of all, thank you. My name is Magda Peck. I've served on SACIMM for the duration of this cohort. I serve currently as the founder and principal for MP3 Health, which is a consulting firm focused on maternal and child health and equity, and storytelling for social change. I also serve as adjunct professor of pediatrics and public health at the University of Nebraska Medical Center, where I also am founder and senior advisor of CityMatch. So what will it take? In a minute, what will it take for research and data, local and state, national and tribal, to be more visible and valued, timely and trusted, available and used to prevent mothers and babies from death and disability, and eliminate persistent inequities? 3 things. First, increased investments in the people and practices, systems and structures for more robust data and research methods and innovative technologies that will augment our shared knowledge and understanding and assure that everyone counts and is counted. Second, strategic storytelling to shape and drive more powerful narratives based on the sound science and lived experience that will change hearts and minds and compel social change. And last, the kind of collaborative, courageous leadership that will give us the wisdom to make difficult decisions together based on incomplete and sometimes imperfect information. That's what it will take to be able to have research and data, local, state, national, and tribal, be the tool we need to be able to drive change for justice and health. Thanks for the invitation. And again, my apologies for joining you late today.
Thank you, Magda. Anybody else appointed members that I didn't see? I think you got everybody. And just for the members who have been recently appointed, when you look at the minutes of this meeting, you will have all of these things that we can backcast from. These are things that you may be wanting to work on in your 4 years on ACIMM. So this is a little template for you to work over the next several years. Let's now go to some of the other folks on our call. Dr. Warren, Michael Warren, could you introduce yourself?
Thank you, Dr. Ellinger and committee members. Good morning. Michael Warren. I'm the Associate Administrator for the Maternal and Child Health Bureau at HRSA. The question I have is, what will it take to get to infant health equity by 2030? As you all know, we have never achieved the healthy people goals for Black and brown babies in this country, and the disparities persist. We know the number. It's 3,700 deaths that we need to prevent every year to be able to get to equity, and I think we can do it by 2030. But what that will take is a focused effort in communities where the excess deaths are the highest. It will take a commitment to do things differently, because what we're doing now has not closed that gap. And it will take an aligned effort to address those underlying social and structural determinants of health. We have to bake that into our funding programs. We have to require that of our grantees, and we have to work with our partners to achieve that. Thank you.
Thank you, Michael. Ann Leach, you don't have to give us your backcasting, but you can at least introduce yourself.
There we go. Thank you. I was having a hard time clicking. I'm not going to backcast because I did not prepare anything, but I just wanted to say that I'm a management analyst who's been supporting the committee in Vanessa's absence while she was on maternity leave. I absolutely love the work of this committee. I find it fascinating, the perspectives that everyone brings to the conversation. And I've also really, truly appreciated the opportunity to get to know the committee's work better and work more closely with Ed as well as some of the members. So thank you.
Thank you, Ann. And Vanessa, do you want to introduce yourself?
Sure. It's hard to follow all of you, but thank you. As Ann and Lee and others have said, I'm just returning from maternity leave as of last Monday, so still generating my brain cells back. But good morning, good afternoon. I'm Vanessa Lee. I'm the designated federal official for this committee, and I work in the Division of Healthy Start and Perinatal Services at MCHB. And just so happy to be here with all of you again and to meet some of the new members. And just wanted to thank Ann, Abigail, Lee, and Ed for keeping the train running as I was out. And I look back at the notes, looks like you guys had a great meeting in March. And I'm just, again, happy to be back and with you all for this June meeting. So thank you. Nice to see you all.
Glad you're back, Vanessa. Let's go through the ex officios to briefly introduce themselves. Charlene Collier.
Hey, good morning. Good afternoon, everyone. I'm Charlene Collier. I'm the chief of the Maternal and Infant Health Branch, located in the Division of Reproductive Health at the Centers for Disease Control and Prevention. Happy to be here.
Good. Cheryl Broussard.
Hi, everyone. This is Cheryl Broussard. I'm the Associate Director for Science in CDC's Division of Birth Defects and Infant Disorders. Welcome to all the newer committee members. I have served on this committee in the past, and today just filling in for Amanda Cohn and Karen Remley, who had other committee commitments today. Thank you.
Danielle Ely.
I'm Danielle Ely. I am the manager of the linked birth and infant death file at the National Center for Health Statistics. I'm glad to be able to attend another one of these meetings, and I am looking forward to seeing what happens over the next 2 days. Thanks.
Good. Glad you're here. Elizabeth Carr.
Good morning, everyone. My name is Elizabeth Carr. I'm the senior advisor to the director here at the Indiana Health Service, and honored to be with all of you today and throughout tomorrow as well. Thank you.
Let's see. Kristen Zeikerman.
Hi, I'm Kristen Zeikerman. I'm the lead on the Maternal and Infant Health Initiative and the Division of Quality and Health Outcomes at the Centers for Medicaid and CHIP services.
Any other ex officio members that are on that I didn't see? All right. And then I think there are other people who will be introduced as we go along, because some of them will be presenters. So we will introduce them as they come along. So welcome to everybody. Thank you for being here. Got a powerful group. We will have more people in and out, but over the course of these 2 days, but we will take advantage of every second that you're here. So with that, let's move to our first item of work, and that's to review and approve the minutes. Do I have a motion to approve the minutes of our last meeting?
So moved.
Joy moved and seconded. I'm sort of listening to the hearings, the January 6th hearing, the thing with unanimous consent, I approve the minutes. I don't know how that all works, but I think it's, if you don't speak up, they're approved. So unless I hear something in the next couple of seconds, I will take that as unanimous consent to approve the minutes and move on. Good. And and the minutes are really, I love the minutes here because they have all of the links to things. Really is comprehensive. If you want more information, those minutes will get you to wherever you need to be. So thank you for all of that. And then, so let us now move forward. So let me give you a little context for our meeting today. 1 year ago at our June meeting, we finalized a set of recommendations that we submitted to Secretary Becerra on August 4th, 2021. In that package of recommendations, we encouraged the Secretary to review the recommendations that we had made a year earlier related to COVID, because many of them were and even still are relevant to today. And we asked him to consider a new set of recommendations related to 5 different areas: care systems and financing of care, workforce, environmental conditions related to maternal and infant health, migrant and border health, and data and research for action. And for the newer, more newly appointed members, it should be pointed out that at least 2 of those content areas really were because of the advocacy of 2 of our members. They had particular passion and were willing to take the work and really move the environmental health conditions. Jeannie Connery moved that, and migrant and border health, Paul Wise really moved that. So there is an opportunity, if you want to take the time and the effort, you can really move an agenda that actually can get some recommendations to the Secretary of Health and Human Services. So that just as a little aside. But among all of the recommendations that we had, there was one, quote, to adequately fund Indian Health Service efforts to reduce infant and maternal mortality and morbidity, end quote. That was our recommendations. And in our discussion of that topic, we realized that the issue of health of First Nations and Indigenous mothers and infants was much bigger and more complicated than what we could do in that one meeting. And that just the level of funding for the Indian Health Service was not the total issue of what really needed to happen. We needed to have a more comprehensive view. So we committed ourselves to a year-long examination of the issues facing Indigenous mothers and infants. And now, while everyone acknowledges that American Indians and Alaska Natives experience some of the worst birth outcomes in the country, some have questioned the wisdom of focusing so much attention on one population group. You know, an obvious answer to that is that this group, because of its relatively small size, it often gets overlooked and deserves more attention, like any group. But I think the more strategic answer to that question goes actually back to the 1912 establishment of the Children's Bureau, which is the forerunner of today's Maternal and Child Health Bureau, and that 1912 vision of its first chief, Julia Lathrop. And she articulated that vision this way, quote, "The greatest service to the health and education of all children has been gained through efforts to aid those who are handicapped. Thus, all service to the handicapped children of the community also serves to aid in laying the foundations for the best service to all of the children of the Commonwealth." Now, let me explain that because it can be taken out of context, but it's because most people think about handicaps or disabilities in terms of individuals and individual characteristics. For example, children with special health needs. And most people usually think of handicap as just an adjective, a handicapped individual, someone who is restricted by some condition or characteristic that puts limits on that person's ability to function in society. But handicapped is also a population characteristic, and it can be used as an adjective, as a noun, or a verb. With a population focus, handicap doesn't describe the characteristics of an individual, but the impact of the actions of our society on a population. And I think it is this population-focused view of handicap that I think was the real power behind Julia Lathrop's statement. With that population focus in mind, think of these definitions that come from the dictionary. Handicapped, an adjective, being limited or disadvantaged by external forces in achieving optimal development and success. Being a part of a system that markedly restricts one's or a group's ability to function physically, mentally, or socially. Handicap as a noun, circumstances that make doing something more difficult, a form of physical, mental, or societal impediment in place that makes progress or success difficult. In a race or competition, a disadvantage of some sort given to someone to make their chances of winning more difficult. And handicap as a transitive verb, implementing a policy or procedure to put someone or a group at a disadvantage. Now, so for too long, we have looked only at the problems of Indigenous individuals, and we have focused and used a disease or deficit focus, which places the onus of the problems on the individual and the solutions to those problems only on their actions. Now, I believe that we should look at First Nations not only as a group of individuals, certainly suffering from some individual handicaps, but mostly as a problem, as a population systematically held back by policies, structures, systems, and stereotypes fostered and sustained by our broader society. So with that perspective in mind, listen again to Julia Lathrop's statement. The greatest service to the health and education of all children has been gained through efforts to aid those who were handicapped. Thus, all service to the handicapped children of the community also serves to aid in the laying the foundations for the best services to all of the children of the Commonwealth. So I believe that our policy and system development work over the next 2 days and in September will lay the foundation for the best service to the mothers and infants, not just to the First Nations communities, but to all of the mothers and infants of our Commonwealth. That is our charge. So over the last year, we focused on a myriad of issues facing First Nations and Indigenous communities. But over the next 2 days, we will be briefed on 4 additional issues, particularly that we have not really focused on. And that is the role of the Indian Health Service, SIDS and SUID, incarceration of pregnant Indigenous individuals, and murdered and missing Indigenous women and girls. In addition, so we'll be briefed on that. In addition, we'll be examining the draft recommendations that were sent out to everybody that have been developed over the last year, and we will work to clarify, refine, and improve those recommendations. And that effort will continue during the summer with the goal of having a draft ready for our September meeting. So this is a step towards that September meeting, which I hope will be here in Minnesota. Now, in the process of developing this current draft, we have consulted with groups serving First Nation communities and been guided by the written reports and articles by Native authors and researchers. But personally, I feel uncomfortable submitting whatever recommendations we come up with without really vetting them with the people affected. That's why in our September meeting will be held on tribal land and provide an opportunity for First Nations and Indigenous individuals and organizations to comment on our recommendations and on the issues facing mothers and babies in their communities before we finalize our recommendations. So in our work so far, it has been really obvious that the issues facing First Nations and Indigenous people are complex and seemingly intractable. But I believe nothing is intractable. Now, I'm not naive enough to expect that our work will resolve all of those issues, but it's an important step in the process that must proceed if we are to achieve equity and social justice for all of the people on this continent. So it leads back to that question that I posed right at the beginning. What will it take to achieve that goal? I believe it'll take the involvement, the commitment, and the prioritization of time of every member of this committee to make that happen. So that's what we're going to be doing in this meeting through the summer and in September. So I really appreciate all of you being part of that. Any questions or comments before we move on to our first session related to SIDS and SUID?
Very helpful comments, Ed. Thank you so much for setting the context so clearly.
All right, and let us see, is Charlene Collier on?
I just got on. Sorry, a little late. Can you hear me okay?
We can.
Okay.
Good. And I had asked Charlene to moderate the first session related to SIDS and SUID. I'm not sure if you're able to do that, given the fact that you just got on.
I'm happy to hop in and with your support get through and everyone else's, but thank you for your patience. I had to do some unexpected travel. So thank you.
Right. So just thank you. So I'll let you take over, but I'm going to make this one statement because I read the Healthy Native Babies Project, and I think it sets the tone. SIDS and SUID, I'll just quote from them, and then I'll turn it over to you to take it from there. It says, American Indians and Alaska Native people experience SIDS and sudden unexpected infant deaths or SUID more than any other racial or ethnic group nationwide. In recent decades, the overall SIDS rate in the United States has declined by more than 50%. However, racial ethnic disparities remain. In 2017, the rate of SIDS among American Indian and Alaska Native infants was more than double that of whites. Further, between 1995 and 2013, there was no significant change in SUID rates among American Indian and Alaska Native peoples, with rates consistently higher than any other racial or ethnic group. Consistently high rates of SIDS, SUID among the American Indian Alaska Native population show that risk reduction efforts are not addressing the most critical factors, are not reaching an AIAN communities, and are not presented effectively for American Indian Alaska Native people. It really highlights the fact that this is a major problem, a major issue, and what we're doing is not working. So that's why we have this session. So I'm going to turn it over to you, Charlene, to take it away.
Thank you. And that absolutely sets the tone and what we're charged to do, which is come up with more transformative recommendations that are grounded in what the Indigenous communities are telling us is what's needed. And so we're really honored today to have a panel to share the background we need on this, and then for our committee to come up with some new recommendations that are progressive and going to be really critical about what has been in place and then what is missing and where we can move forward. So We have first our team from HRSA, which includes Diane Pilkey, please correct me on the pronunciation, and Maureen Perkins, who will be first presenting, followed by Abby Collier, who's the director of the National Center for Fatality Review and Prevention, and then we'll move on to our final presenter, and I'll introduce as we get closer. So we have the slides up. Diane and Maureen, are you on? I think you're muted. Diane and Maureen, I guess, need to be unmuted. I see Maureen. And Diane, gotcha. Are people able to hear Diane?
It looks like she's on mute, but she's figuring it out.
Yep. And Maureen, how about you?
Can you all hear me?
I can.
Okay.
Can you hear me now?
Oh, I think we
Yes.
have Diane.
Sorry. I don't know why
Great.
this didn't work. I apologize. I'll go ahead and get started, and good morning, and thank you for inviting us to present. My name is Diane Pilkey. I'm a senior nurse consultant in the Maternal Child Health Bureau in the Division of Child, Adolescent, and Family Health. I'm the federal project officer for the National Center for Fatality Review and Prevention, as well as the Children's Safety Network. And my colleague Maureen Perkins is a public health analyst in the same division and oversees our division's safe sleep and sudden unexpected infant death or SUID portfolio. Next slide. So we will be presenting on some of the SUID prevention investments in the Maternal Child Health Bureau, and then turning it over to Abby Collier, the director of the National Center for Fatality Review and Prevention, who will share some of the data collected from child death review teams on Alaska Native American Indian SUID deaths. Next slide. The Division of Child, Adolescent, and Family Health houses investments related to advancing health promotion, injury and violence prevention, and improving and expanding emergency medical services and systems and preparedness for children, adolescents, and families. Next slide. I think we all know the definition of SUID, but I put it up here anyway. It's the sudden and unexpected death of an infant, which often occurs in the baby's sleep area. And every year, about 3,400 babies die from SUID, which includes deaths from SIDS, accidental strangulation and suffocation in bed, and deaths from unknown causes. Next slide. Between 1990 and 99, families responded to providers' health messaging that recommended infants be placed on their back to sleep, which resulted in a significant decline. However, for the past 20 years, the rates of SUID have remained essentially unchanged. And as Dr. Erlinger stated, that this downward trend has not been seen in all groups. Next slide. There are elements of SUID prevention and safe sleep work throughout Maternal Child Health Bureau, including in the Title V Block Grant Program, Home Visiting, and Healthy Start. This slide lists some of the national Title V measures that are related to SUID prevention. 36 states and jurisdictions have chosen to focus on National Performance Measure 5, which promotes safe sleep environments for infants. And states are able to measure their progress using data from their Pregnancy Risk Assessment Monitoring System survey. Next slide. This one's a little hard to see, I apologize. This shows the national data from the 3 PRAMS indicators over time. The blue line is putting infants back to sleep. The green line is placing infants to sleep without soft objects or loose bedding. And the yellow measures whether infants are sleeping on a separate approved sleep service. Next slide. The first program we wanted to highlight is the National Fetal, Infant, and Child Death Review Program. MCHB funds a national center through a cooperative agreement to the Michigan Public Health Institute. The goal of that cooperative agreement is to increase the capacity of child death review and fetal infant mortality review teams to do fatality reviews, collect high quality uniform data, disseminate the findings from their reviews, and make some recommendations to prevent future deaths. Findings from these reviews can help us better understand the circumstances preceding these deaths and can lead to improved systems of care and more targeted programs and policies. Next slide. Just a little bit of background on the case reporting system. This is the National Fatality Review Case Reporting System is a free web-based data system established for child death review teams in 2005, with FEMUR teams coming on board in 2018. You should have a handout in your materials that describes the system in more detail. Participating states can enter into a data sharing agreement with the center to use the case reporting system. And the system allows local and state CDR and FEMUR programs to enter their case data, summarize their findings. They can download their own data. And it also has standardized reports as well as the ability to create some data visualizations. Currently, 47 states are entering data into the case reporting system. And based on the data sharing agreements with the center, a subset of states allow their de-identified data to be used to create a researcher database. Next slide. The National Center is a key resource for collecting information on these SUID deaths. The CDC SUID registry builds on the work of these child death review programs, and their SUID grantees use the National Center's case reporting system as a basis for their data collection. The researcher database that I mentioned on the previous slide has detailed information on more than 28,000 SUID deaths. Beginning in July, new expansion funds will be available to support the National Center to enhance support to states, communities, and tribes in order to increase the use of the case reporting system for SUID, as well as sudden unexplained deaths to children, with an emphasis on teams not currently supported by the CDC SUID registry. Another goal is to increase data dissemination and data-informed prevention activities related to SUID, as well as SUDC. This includes producing summary data reports, creating a public-facing data dashboard, and increasing the use of the researcher data sets. Next slide. MCHB also funds the Children's Safety Network through a cooperative agreement to the Education Development Center. This program supports the work of Title V and state injury programs in their efforts to reduce fatal and serious injuries among infants, children, and youth. The focus is to support improvements in the adoption of evidence-based policies, programs, and practices in priority topic areas related to common MCHB performance measures. The Children's Safety Network does this through training and technical assistance, learning collaboratives, and resource development such as webinars, fact sheets, publications, and infographics in a wide range of child injury prevention topics. Next slide. Children's Safety Network has initiated 3 child safety learning collaborative cohorts with 10 states and jurisdictions who wish to focus on the prevention of SUIDs. You should have a handout on this as well. Participants in these learning collaboratives receive online learning sessions that offer in-depth guidance on implementing and spreading evidence-driven strategies and programs. They receive customized coaching and technical assistance from national experts, and they utilize an online workspace to report their child safety activities and get feedback and guidance from the Children's Safety Network. In the SUID collaborative, states and jurisdictions selected the evidence-based and evidence-informed strategies that are most appropriate for their own state's SUID prevention goals. Some examples are listed here. For example, 241 hospitals or birthing facilities provided safe sleep training to healthcare providers. 48 home visiting programs distributed safe sleep education materials. 52 organizations implemented evidence-based safe sleep campaigns. And now I'm going to turn it over to my colleague, Maureen Perkins, who's going to talk about some of the other SUID investments in our bureau. Next slide.
Thank you, Diane. So Most of our work on suicide prevention is based on the 2016 American Academy of Pediatrics Task Force on SIDS policy statement and technical recommendations. You'll see some of the recommendations listed here on this slide. And also to note that a revised policy statement should be released later this month. Next slide. So even though we have these recommendations, there are variations in suicide rates across the states. These variations have been attributed to poor pre-pregnancy health, tobacco use, access to quality care, socioeconomic inequity, structural racism, and lack of programs and policies that support parents, like home visiting and paid parental leave. Next slide. So some of our previous work on Safe Infant Sleep, to give a background, in 2014, we funded the Safe Infant Sleep Systems Integration Program, which established a national coalition of various stakeholders called the National Action Partnership to Promote Safe Sleep. They were focused mainly on integrating the messages around safe sleep promotion and breastfeeding promotion. In 2017, we funded the National Action Partnership to Promote Safe Sleep Improvement and Innovation Network, which continued the coalition, added some quality improvement components, and focused on health equity and ensuring our messages reflected the needs of communities. Next slide. Our colleague, Dr. Ashley Harai, conducted a study showing that while parents report receiving specific safe sleep practices, such as back sleeping, they're less likely to receive information about other recommendations, like placing an infant to sleep in a crib, reducing clutter, or room sharing without bed sharing. So we believe some different approaches are needed to help providers more fully educate and counsel infant caregivers. Slide. So our new suicide prevention program launches next month. It's been awarded to the American Academy of Pediatrics for goals to reduce racial and ethnic disparities in suicide. We will be focusing on using the data and findings and recommendations from ACIMM and CDR reviews, helping pediatric providers to provide counseling, implement community action teams, and support them to offer more culturally responsive care. Next slide. Here is our contact information for myself and for Diane. And I will now turn the presentation over to Abby Collier, who's the director of the National Center for Fatality Review and Prevention.
Excuse me, thank you very much, Maureen, and good morning, everyone. It's such an honor to be here with you today, sharing some information that we have gleaned from child death review teams. Next slide, please.
One sec, I'll pull it.
As we are waiting for the slides to come up, I just want to acknowledge that my colleague Rosemary Fournier is here with me as well today and is our femur expert. And although I'll be sharing data specifically from child death review, we know there's significant implications on the femur side as well. Next slide, please. So Diane very succinctly talked about the case reporting system and how it's used. Just a visual to point out, it's used in 47 states for child death review. 18 states use it for femur. But I think the key message on this slide, at least, is that every state uses it a little bit differently. Some states enter 100% of their cases. Other states enter 10%. Some states only enter certain causes or manners of death. Some states enter them all. And that can make it challenging to use case reporting system data, but despite its limitations, it is a very unique and valuable data set. Next slide, please. We do want to point out that data from the case reporting system are available for research purposes. Sleep-related infant death is the #1 research topic on child death review data, but anyone affiliated with a research institution can submit an application and access the data to conduct your own research. Next slide, please. All right, so now we're going to jump into the actual data that we ran out of the case reporting system. As Diane said, we maintain the case reporting system, and additionally, we have what we call a research data file. That research data file contains fatalities where the state has given permission for them to be shared. We found 28,110 infants who kind of met the criteria for an unexpected infant death. So they were SIDS, a SUID, an ASSB, or an undetermined. Of that 28,110, 866 of those infants had a race of American Indian or Alaska Native listed. I do want to point out that in our data, we've recently started recoding and representing racial data a little bit differently. We discovered that American Indian, in particular, American Indian infants or children were overrepresented in our multiracial group. They comprised about 30% of that group. And in order to better reflect the risk in the community, we have defaulted our data analysis to pull out American Indian, Alaska Native children, regardless if they have another race listed. So the data that we're going to share with you also includes children or babies where the race was just American Indian, Alaska Native, but it also includes cases where it was American Indian, Alaska Native, and maybe Black or white. This is a little bit different than how we handle the rest of our data, but it was consistent with feedback we received from some subject matter experts, some of who are with us today. The last thing I want to point out about these data are that the missing and unknown amounts vary depending on the question, and they are excluded in the following analysis. So what you'll see is only data presented as yes, no, or whatever the variable options may be. In preparation for this meeting, we knew that there was a number of specific data points this group was interested in, and unfortunately, we were unable to provide data on 3 of those. The first was postpartum visits. It was missing 96% of the time. For infants being born drug exposed, it was missing 70% of the time. And excuse me, infants experiencing neonatal abstinence syndrome, that was missing 84% of the time. There's a number of reasons why we think these missing are so high, and some of them being that these are newer questions to the case reporting system, but we did want to point that out for you. Next slide. There were no differences between American Indian, Alaska Native infants and other races for age or manner of death. So you won't see those displayed here just for lack of time. What you see up here are factors present in unexpected deaths. And the first circle is a history of maltreatment. This is asked for all cases in the case reporting system. 21.9% of infants who had a race of AIAN had a documented history of maltreatment compared to 12% of infants of other races. We went on to look at overheating, as that's a risk factor from the AAP. 8.4% of American Indian, Alaska Native infants had overheating indicated at the time of death compared to 44.2% of all other races. If we look at breastfeeding, 70.9, so 71% of AIAN infants were breastfed at least once, and that compares to 57.1% of all other races. And then for birth weight, we found that 16.3% of AIAN infants were born weighing less than 2,500 grams compared to 21.9% of all other races. So kind of see in the slide, higher percentage of reported breastfeeding, fewer infants being born, low weight, but potentially a higher history of maltreatment and more likely to experience overheating. Next slide, please. So in this next slide, we wanted to talk about smoke exposure. I know there was sort of a lot of interest in that. So for smoking during pregnancy, the numbers were actually very similar. 49.3% of infants were exposed to smoke at any time during the pregnancy, and then compared to 48.8% of all other races. And then after delivery, there's a little bit of a difference in smoke exposure here. 60.3% of AIAN infants were exposed to smoke at some point after delivery, compared to just under 50% of all other races. Next slide, please. One of the questions was the infant placed in a new sleep environment? And you could see, 23% of AIAN infants were in a new environment, but the numbers are very consistent with what we see for all infants. Next slide, please. So room sharing and surface sharing, I feel like this is often the big question when we start to talk about particularly sharing the message of sharing a room but not a surface with infants. So we found that 77.7% of AIAN infants were room sharing, compared to 71.4% of all other races. So a little bit higher percentage of AIAN infants were room sharing. If we look to the middle box, that's surface sharing. So we found 69.3% of AIAN infants shared a sleep surface, compared to 65.4% of all other races. So again, it's a little bit higher, not too terribly different. And then this last one is sort of the AAP recommendation of share a room but not a bed. And we found 14.9% of AIAN infants were room sharing but not surface sharing, compared to 16.4% of infants of other races. Next slide, please. So here we looked at the sleep surface. Where was the infant placed to sleep? And for the most part, you can see there is a fair amount of consistency between AIAN infants and all other races. The one thing that was sort of notable was in the percentage in adult bed is higher here. And on the previous slide, we pointed out that AIAN infants were slightly more likely to sleep on a shared surface. So this is actually showing us consistency in the data, which is a good sign that the data are being entered correctly. So I think, you could safe to say that AIAN infants might be more likely to be in an adult bed. I do want to point out that crib/bassinet really is any sort of portable crib too, like a pack and play fits into that definition. Couch or chair also includes pillows. And then the items that fall into other are things like a water bed or that's really what's in other. Next slide, please. So one of the things that we talk about when we share our data is that we know data quality can be lacking, and there's a number of instances where we're asked for data, the teams try to collect it, and they are unsuccessful. So people ask me often, how could you fix that? And I think the answer to that is twofold. First is to improve consistent access to records throughout the US. As the laws stand right now, they're typically state-based and open to interpretation. So there's a lot of variation, even for states that have really strong legislation. And then the second piece is resources to support data collection and entry. Through our work with the SUID and SDY case registry that Diane mentioned, we have seen those jurisdictions that are funded have a pretty drastic improvement in their data quality and completeness. Next slide, please. And again, thank you so much for the opportunity to come today and share with you some of the data from the case reporting system.
Thank you, Abby. So we'll pull up our last presenters and then we can open up for some questions. I know there are a couple in the chat just talking about infants being ever breastfed. So we'll pull up our next speakers. So we have really privileged to have Shira Rutman and Kendra King-Bowes joining us from the Miami Environmental and Energy Solutions. And they work very closely with research on SUID and SIDS in the Native American population. And we are glad to have you join us, and your full bios are in our program book, but we'll let you jump right in so we'll have plenty of time for questions.
Thank you so much. And thanks to the presenters who shared just before me. It's really interesting to see some of those data, and I'm grateful to be here. My name is Shira Rutman, and I'm a consultant with the Miami Environmental and Energy Solutions, which is owned by the Miami Tribe of Oklahoma. I'm sorry to say that our managing director, Kendra, is not available to join me today, but I do see that one of my cherished colleagues, Lee Tanner, is here and is a partner of ours on this project. So I'm here sharing information that was gathered as a part of the Healthy Native Babies Project, and this was previously funded by the NICHD. I'm including a QR code here so that you can see some of the background of the project. So for those who are less familiar with that technology, you just point your phone camera to that icon and it should bring up a link to more information about the project. So I do want to acknowledge, in addition to Lee, the rest of my colleagues on this project, Geraldine Simpkins, Kristen Halvey, and Marie Zafir. And I want to say that I'm dialing in from San Francisco, which is the ancestral land of the Ramaytush Ohlone. I'm also an analyst at the Philip Arley Institute for Health Policy Studies at the University of California, San Francisco. And I want to thank Dr. Palacios for inviting us here today. I'm going to be talking about insights on safe infant sleep in Native communities. Next slide, please. So between July of 2020 and May of 2021, our team conducted key informant interviews with 16 individuals. And these were program directors, healthcare and social service providers, health educators, and a spiritual elder, all who are working to address safe infant sleep in Native communities. And they were based at tribal organizations, at hospitals, at Indian Health Service locations, urban Indian health programs, and university and state-based agencies serving Native populations. They were located in 8 different IHS regions, so we were lucky to really capture a broad range of experiences and perspectives with this group of experts. And there was so much rich and critically important insight shared with us in these interviews. I'm only going to be sharing some highlights with you all today. We are hoping that the full report summarizing our findings will be posted on the NICHD website at the link, again, at the QR code listed sometime in the near future. Next slide, please. So while our interviewees were a diverse group, we actually heard very consistent themes across them. And these really highlighted the systemic risk factors for SIDS in Native communities and the importance of viewing the context for communities as well as individual families. They talked about how the history of colonization, ongoing oppression, and structural racism continue to impact communities' efforts to reduce SIDS risk. And these experts also spoke about the need for policies that address common and persistent challenges, especially in housing and healthcare. I'm going to share more about each of these next, and I know some of the data as I interpret it that was shared by my colleagues just before reflects this as well. We asked these experts for recommendations and again heard some consistent themes, and I'm going to highlight these now and then I'll talk more about them. The importance of early and ongoing education on SIDS risk reduction was one, and really starting with birth workers and home visitors during pregnancy and including all extended family, especially elders. They also recommended strengthening collaborations across providers and educators for consistency and persistence in safe sleep messaging and improving on training for all providers serving Native communities. They recommended building on cultural strengths, which included traditional activities and culturally specific care. And really, Native communities and organizations should be funded to design and lead all of these efforts. Next slide, please. So looking at the data in a bit more detail, first I'm going to share some of the barriers and challenges that our experts identified for us, and then I'll talk about some of the strengths that were shared. Next slide, please. When asked what makes it difficult for Native families to practice safe infant sleep, one participant summarized the most common issues, saying there are challenges in the built environment, living in multi-generational families, living in homes where there is substandard housing, babies may not have a place to sleep safely, and parents may struggle living with elders when they try to insist on or demand smoke-free environments. The experts we interviewed all underscored the need to address the root causes of SIDS risk factors experienced by Native communities, including taking a holistic approach to safe infant sleep by prioritizing funding for policy-level interventions, in addition to individual-level approaches with families. We also heard that the COVID-19 pandemic has exacerbated housing and healthcare challenges for these families. Next slide, please. Within the challenges summarized in the quote that I just read, overwhelmingly, the most common shared was a lack of money and space for a separate sleep surface. And these are a few quotes highlighting this issue. People are limited based on what they can afford. There are people who are couch surfing. It's a much harder conversation with families who don't have the spaces to reinforce safe sleep practices. Next slide, please. Additionally, we heard about the impact of housing insecurity, especially among Native youth, on access to safe sleep spaces, which is reflected in this quote. It says, I think for the young parents not having a home of their own, kind of going from home to home, whether it's the father's parents' home or the mother's parents' home, moving temporarily from one location to the other, I think that's part of why cribs are not being used, besides the financial factor. And again, I was interested to see some of those percentage differences that were shared by Dr. Collier to this effect as well. Next slide, please. The second most common challenge to safe infant sleep described in interviews with our experts was barriers to healthcare. For some clinics in tribal areas, there is no in-house prenatal care or obstetrician, and obstetricians can be a long distance from tribal areas. Case managers at Indian health clinics may not receive any communication from an obstetrician, which was explained by one key informant who said, you may see one family medicine doctor who takes care of you before baby comes, another one who delivers you, and then me for pediatrics after baby arrives. It's not always a consistent message across everyone, and that can be confusing. Another issue within healthcare described by a few of our participants was cultural insensitivity and racial incongruence between healthcare providers and patients that leads to a lack of uptake of safe sleep recommendations. And I know this committee has drafted some recommendations related to focus on educational pipelines for Native people in medicine and other scientific fields, which I think is relevant here. Next slide, please. One key informant explained challenges with non-Native providers trying to serve Native families as follows. When it's coming from someone like me, who is not Alaska Native, when I say, let's get a bassinet and put the baby there, it can be taken as me saying the cultural practice is inadequate. It can come across as me challenging generational ways. It can come across as condescending and almost a form of cultural oppression. The primary recommendation around this issue was focused on cultural sensitivity training for healthcare and social service providers to help address barriers for families accessing services and wanting to engage in traditional practices, traditional healing practices in particular. Part of this is the need for education and understanding about the history of colonization in the United States and the ongoing impact on Native people, including infant outcomes like SIDS. Next slide, please. Next, I'll share a bit about recommended approaches for safe infant sleep in Native communities that our experts shared with us. Next slide, please. Several experts that we interviewed also spoke to the value of a risk reduction approach. And one said, my lessons learned really are lessons about the importance of a harm reduction approach. Not everyone will be able to meet all of the requirements that constitute a safe sleep environment. It's important to meet people where they are. Patient-centered care, which also encompasses holistic care, was described by several of the experts we spoke with as an essential approach to safe sleep promotion within Native communities. And one of them explained this as making sure you can ask questions and have conversations without making people feel shame. I participated back on the NAPS project in 2014, and I know that these conversations were a big part of that focus. And patient-centered care is defined as when an individual's specific health needs and desired health outcomes are the driving force behind all healthcare decisions and quality measurements. Patients are partners with their healthcare providers, and providers treat patients not only from a clinical perspective, but also from an emotional, mental, spiritual, social, and financial perspective. And this holistic approach is also in line with Native traditions. Next slide, please. Multiple experts we spoke with recommended early and consistent education, including the best timing as during the prenatal period, or if that connection is not made, then before the family leaves the hospital or birthing place. And they highlighted opportunities for birth workers to include safe sleep education. A couple of experts commented as follows. Education should be provided by obstetricians to give the moms time to think about it, look it up for themselves, and create plans before the baby ever comes. Another said, we could be utilizing individuals that work with moms that do birth work. Our birth workers like midwives, doulas, and groups who support women postpartum. Those groups could really be solid places where we could talk more about harm reduction and supporting families. Next slide, please. Our interviewees noted the need to engage fathers and multi-generational caregivers. One said, we really need to be creative in including the father. Everything's mom, mom, mom. And fathers need to understand that they have a responsibility too. Including that father perspective, I think, would be helpful. This next quote says, there are many people caring for an infant. It is really important that the education extend beyond the mom and the dad. Bring in grandma, grandpa, aunties, uncles, the whole extended family. Next slide, please. Several experts we spoke with commented on the need to support healthcare and social service providers and educators in safe sleep education. This included ways to foster collaborations across providers and organizations, such as creating a forum for sharing lessons learned and ideas for mutual support, providing ongoing professional development, including the training that I mentioned previously, promoting continuity of care through policies and practices for referral follow-ups was also recommended. Next slide, please. Finally, I want to go over some of the strengths that were shared when we asked about traditional and cultural practices to support safe infant sleep in Native communities. Next slide. The most common response when we asked about traditional and cultural practices for safe infant sleep in Native communities was the strength of the extended family. One of our experts shared this quote: "Many family members take an active role in helping to raise these children. Really, the community helps raise them." This also encompasses social support. A few of our experts talked about the opportunity for community events and support groups as ways to build on community strengths for protective factors. One shared the following: "When families are connected to community and to other people in the same phase of life that can support each other, those are places where safe sleep messaging and harm reduction could really be happening." Next slide, please. These experts also talked about how traditional practices and teachings can be opportunities to build on strengths-based approaches to education and to incorporate education about safe infant sleep. Some of the examples they shared were beading, baby wrapping, dancing, traditional dancing, breastfeeding, powwows, gifting star quilts, and sacred tobacco. We also asked about the use of cradle boards specifically, and most of our experts shared that there was a high level of interest in and use of these traditional items. You can see a picture of that in this image here. A cradle board is a baby carrier to keep babies safe, secure, and comfortable, while at the same time allowing the mother's freedom to work and travel. They consist of a frame made of natural materials and are decorated with materials and in a style that varies from tribe to tribe and regionally. It is flexible in use. It's decorative and protective, and cradle boards, I should note, should not be used in lieu of car seats, which is always a part of the discussion in introducing these items. Next slide, please. The theme of culturally specific care was one of the key lessons shared with us from the experts we interviewed. One said there are over 500 tribes in the US, and they all have things that are very unique to them. It makes it challenging, but Native people want that connection, and people outside of Native community work and cultures may not understand at all how important that is. Again, this really highlights the importance of integrating and building on cultural teachings in safe infant sleep education and allowing supporting and funding Native communities and organizations in leading this work. Last slide, the last quote I'll share is on the next slide. I think. Yes. The last theme that we want to share from our experts is the diversity of practices and traditions across Native communities and within families, which are protective for safe infant sleep. This can be from tribe to tribe, urban area to rural area, and in different families, some of whom are traditional and others that didn't grow up with traditional teachings. This theme really highlights the importance of tailoring efforts to the communities and individuals being served. And again, for these efforts to be community-led. I don't think I can say that enough. I'll read this quote. "We have far more strengths in our communities, within our cultures, within our languages, and within our ceremonies. We have far more strengths than we have barriers or challenges. And to draw on those is really important, and connect those to whatever we are trying to affect change in is really important." And I think that it's really important to end on that note of building on the strengths and listening to the communities that have the answers to these challenges for them. Last slide, please, is my contact information is here. Again, I have the QR code, which will bring you to more information about the Healthy Native Babies Project. And my email is listed there, as well as a little background information on some of my work listed on the UCSF website. I'm happy to be in touch with anyone to follow up around questions or more information around the work that we do and the work that I've done in partnership with Native communities. So thank you for giving me the chance to share today.
Thank you so much, Shira. That was amazing information and very powerful. And I think it certainly sets the foundation of where we need to start as a committee for our recommendations. So I'll just ask all the panelists to come back on camera if you're able to. And then if any of our committee members want to open up with any questions or comments. Yes, I see Magda's hand up. Why don't you go ahead?
I'll give a start. First of all, brilliant. I'm delighted with this session and for all the preparation that went into it, and the combination of both the qualitative and quantitative data. And I'm curious about the disconnect between the surveillance system of Title V data first presented in Measurement 5 by the 36 states that do collect this, the data that comes from the fatality review systems, which are contextual data, but not a surveillance system. And then the qualitative data that can come from the experts when you ask people directly what's needed. And one of that disconnect, I was hoping that maybe we could have a conversation around that relates to an earlier session at ACIMM in spring, which has to do with housing. And I was just noting that in the data that are collected both in the by Title V performance and even the measurements and that which is taken in the fatality review, I just don't see any systematic focus on the context of housing instability and the expectation that our educational materials around safe sleep will fit a quite different reality of, especially accentuated by COVID that Shira brought up. So here we hear from the experts and what's happening, that housing is a big deal, but I don't hear anything asked about the housing context, but only the specific surface and whether you're sharing with mom. And there seems to be a disconnect. So I was wondering, how can housing context be brought into as just one example of what we're asking and collecting systematically, and what is the lived experience and reality that we're hearing from the field. And maybe if the folks at MCHB could start first, and maybe Abby could go second, just to how do you respond to what you're hearing the field and folks say?
Thank you, Mata.
Diane, you want to start? Yeah, great. I know you know it, but how do we collect it? How does the data?
I think that's a really good and important question. And actually, I was going to defer to Abby, because the center has been making efforts to, where they've added questions to the case reporting system about life stressors. And also they do collect some data about how related to that on housing. And so I'm going to defer to Abby to address what we've been doing in that context to collect better data.
Magda, I saw your hand go up. Did you want me to wait?
No, I'm going to come back to you, Diane, with complete respect, because here we had Dr. Cho with us talking about trying to build the connections with housing and urban development, and how housing and health are essential for health impact. And I'll ask if you have any connections on your end at the cabinet level with housing around systems and infrastructure and training and cross-sector connectivity. So yes, pass it to Abby, but that's what I'm hoping that you'll also be able to come back so we build on our earlier ACIMM work.
And I'm going to refer that up the ladder in the Bureau. Perhaps
I'm putting you
on the spot. Dr. Warren, about the connections that are being made, at a broader level than within these, in our individual programs.
Sure, and Dr. Peck, happy to weigh in. So we do have a relationship with HUD, and I think that relationship has really been growing over the past year, both around maternal and infant health. So with the administration's work on addressing the maternal health crisis, HUD has been a partner with us. And we have a federal work group of federal partners around infant mortality and this question of getting to infant health equity by 2030, and HUD has been there as well. So happy to take what the comments we've heard today back to that conversation, but they are there and very eager to be not just at the table, but engaged.
I'm so happy to hear that. I just want to say, if the data agenda and the infrastructure and the cross connectivity of what we're learning and surveilling, if the data could speak to each other, we might have a more robust picture of how policy can change and know the changes that we make are making a difference that we want. So thank you.
I think that's really important. One thing I will say on the data piece, this was new to me. It may not be new to all of you. our HUD partners shared with us the time in our lives where we are most likely to be unhoused is the first year of life. And that was a surprise to me, but I think really insightful as we think about moving forward. So.
Joy, you have your hand raised.
I do, thank you. I really appreciated Shira's presentation. I work with the State of Alaska Maternal Child Death Review, and what struck me when I first started with that committee was that there weren't people at the table from the communities where the deaths were happening, and so seeing what you guys do in California to bring people to the table is really encouraging, and I'm wondering if at some point you could come and speak to our group in Alaska.
Thank you. Yes, I agree. And I probably said it many times that, having the, so I'm not a Native person, and, I'm an ally and been working in partnership with Native people and Native organizations for a number of years, and can only do this work. I'm in an honored position to be able to share the voices of the experts and work with my Native community partners to share those voices, and can really only, represent folks when I'm asked to do that. But would be happy to continue those conversations and reconnect with some of those colleagues. And we do have a person on our Healthy Native Babies team, Kristen Helvey, who's an Alaska Native woman. Sorry, I'm forgetting her tribal affiliation at the moment. I believe she's at the Baskin, actually. And anyway, so I'd be happy to reconnect with some of those partners and try to make recommendations for you about whether myself or someone else might be able to come speak with you. But I really appreciate your takeaway from that and taking that opportunity.
Thank you so much, Shira. Dr. Menard.
Thanks, Charlene. Thanks to all the panelists. I'm learning so much from you every minute. What I'm hearing, I guess I'm hearing, 500 tribes, all very unique, diverse communities, and the need to honor those differences is really important to this work. And then I hear the absolute need for cultural sensitivity training, for our workforce at every level. And the confusion that comes when practices and best practices aren't conveyed consistently between the prenatal care provider and the, maybe the intrapartum nurse or the pediatrician, and the confusion that comes with that. But I'm wondering, and I think my question is directed towards Shira to comment, is how do we reconcile that? The need to really kind of meet the broadly diverse yet come together with some recommendations and potential policies and support that will meet that broad, kind of diverse community that we need to support.
Janelle, did you?
Yeah, sorry. I think I heard that was asked. That was a question to me.
Yes, if you can,
okay.
Yeah.
So I know that there are, as we've heard from the partners that we work with, that there are some of these recommendations around, especially as the last slide that I shared describes, their, tribal communities are as diverse as any other, group. And so, some folks are connected to their traditional practices, others are less so. It depends on the community and the family that they've grown up in. Some folks are seeking out those connections, even if that isn't something that they've grown up with. And so I would say that really creating opportunities for some of the organizations that have been serving that have been serving tribal people and communities for time. I'll share one example, which I actually should note as a correction in the agenda that you might have seen, I'm listed as affiliated with the Urban Indian Health Institute. I did work at the Urban Indian Health Institute for many years early on with Lee, actually, and some of the work that she's done over the years, but I don't anymore. However, they are one of a number of tribal epidemiology centers funded by the Indian Health Service and others, who are just one example of partners who serve a broad range of regions and tribal people who could support designing and supporting efforts to implement diverse tribal people. So I would say that really ideally those interventions and policies should not be designed just at the national level, but that should really be designed in partnership to be implemented with regional partners as well. But they're also, many of the recommendations that we heard are relevant across Native people about how to take that approach. So I think that there can be really a combination of doing that, and the fact that that tribal people are diverse should not be a reason to not take those steps that we know can be effective in moving forward. And I'll just note, as I've seen the HUD comments and comments on housing, I am familiar with a Broken Promises report that was published in 2018, which has quite a bit of detail specific to the housing issues and recommendations by the, I'm sorry, I'm going to mispronounce the name if I try to make a guess, but you can certainly Google the 2018 Broken Promises report. And again, there's a whole section of recommendations. So this is certainly not the first time that we're hearing the connection to health outcomes and housing. And so I'm so delighted to see that folks are picking up on the potential for how to integrate that into these recommendations.
Thank you again. Dr. Palacios, Janelle?
Thank you. Thank you to the presenters. It was really engaging and has shared quite a lot of information for us to consider. And I want to also thank Abby and Rosemary for the work you did in determining who was included in the analysis, that it was multiracial, American Indian, Alaskan Native people were included in that, because as inherited from our colonial history, there are definitely big identity concerns related to that. So thank you for including multiracial Native American people, regardless of all the other ands and ands and ands and ands, and definitely I'm one of them. But I'm just kind of thinking going back to what Ed said earlier, and then also going forward of what we've heard today, that what I'm wondering, what other questions, what other variables are needed, Diane and Abby, on these reviews, on these surveys, on these forms that will get at more of the social determinants of health, contextualizing the infant safety, right? And as we heard from Shira Rutman today, the experts who were contacted and give their lived experience, that as a provider, someone saying, oh, you just need to buy a crib and place it here, and knowing that this family or community is, has high housing instability, that the reports or the variables shared with us, bed sharing or space sharing and room sharing was high, likely for Native American infants and families. But what else is missing? It was good to see that there was something indicative of maltreatment or abuse or violence in the home. And of course, that's just what was reported or disclosed, right? It's not at all telling us the full picture. But what other variables could be added? Because the way sometimes that the data is presented, again, it puts the blame back on the family. Well, they were sharing, they were co-sleeping, or they were smoking postpartum. Well, there's a lot of context to that, as we heard, the multi-generational families living together. So I'm wondering what other variables could be added, and if you have a thought as to where you would go to confirm, maybe it's additional lived experience, additional community experts or partnering with a Shearer's group to understand what other questions could be added. Thank you.
That's such a great question, Janelle. I put in the chat the link to the data form that we use. It does show you all the variables that we collect. And about 2 years ago, we added a section called life stressors that's meant to get at those contextual factors we're talking about: housing instability, neighborhood violence, relationship discord, for older kids looking at things like transitions in and out of school, in and out of child welfare, juvenile justice, etc. We would really welcome any feedback on how to improve and expand this section. We added, actually today, the next version of our data system went live this morning. And in this new version, we have a section on medical life stressors. We're hoping to better understand the barriers that families experience. But if you look through these and you have suggestions, we would absolutely welcome them. And as we start to think about version 6.1, which we get just a tiny break before we start planning for that, I really love the idea of engaging with some folks with lived experience to hammer these out a little further. So thank you so much for that recommendation. So I would just say we're getting there. We're excited about these, but we're not all the way there yet. It's a good start.
No, and that's exactly the whole point of, we are understanding that context is so important. And I was just reviewing as you were sharing, Abby, so that it's not race, which has been the issue for much of the research on disparities has been placed on race. It's right, it's all the other factors. So it's also the racism. That's really what's at stake. So thank you. It's wonderful. And I will be sharing with colleagues.
Ed, you had your hand raised.
Yes, I have more of a comment. We've talked about the importance of narrative and what the narrative and how that shapes what we do. And so I hear some discordance in the narrative here. We hear the story about how it's all the social factors that really impact SUID and SIDS. And yet we talk about patient-centered care. Why aren't we talking about community-centered care? Because all health is within relationships. And similarly, the grant that was given to address SUID, going to the American Academy of Pediatrics. I mean, I don't know all of the reason behind it, but it medicalizes this issue, but it's an individual problem when really it's a community problem: the housing, the racism, the environmental contaminants, the economic insecurity. So I think we need to think about how we shape our conversation and how we change the narrative. You know, for me, bias, I try not to use, I know we want to focus on the individual, give good care, but I think we need to do it in the context of the community. So I think, you know, think about that narrative as we move forward.
Dr. Peck.
Two very more granular questions, if I could. And Abby, I think this one comes to you. First of all, thank you again to the National Center for running special analysis. Thank you for letting us know that they are available and being open to change. Can you give me information about all of the both child death review, of which there are hundreds, and the FEMR sites in the country? What proportion of the community review teams include tribal members, Indigenous people? Do we have a sense that built into the Sentinel event review methodology, the Fatality review process, they're not just people we consult with? This is Ken Harris's comment in the chat. Thank you, Ken. But there's actually at the table of the reviewers who are interpreting the data that are coming out. Can you give us a sense of what the demography is of the composition of death review teams in both fetal, infant, and child death review that would give us confidence that there are Indigenous perspectives and lived experience at the table? So that's one question of data about the infrastructure, very specific. And the second is, if we're doing this kind of questions and surveillance, we were asked to consult on PRAMs a year ago. As you think about making systems more robust, one of the recommendations that Shira Rutman came out with, and it's brilliant, Shira, the last part, from listening to experts, is what about moving shame to strength? And what are the strengths that we build on? So a generic question in the whole process that we're doing here of data and specific to SUID and SIDS is, do we capture any data on family strengths, on community strengths? Like, there's a whole methodology that has been created in terms of strength-based and asset-based methodologies, but we tend to think about risk and negative outcomes. So I'm wondering, is this an opportunity to restructure the social DNA of our surveillance systems, of our case review systems, to also highlight some of the more protective factors that build on cultural and traditional strengths, in addition to practices like breastfeeding?
Those are both
very specific questions, so good luck.
Yeah, thanks. Both good questions. I can answer the first one with sort of a non-answer. I'll get back to you. The participation from American Indian, Alaskan Native communities on fatality review teams is incredibly variable. We actually have a virtual national meeting later this week, and I'll ask the question and see what people say around current participation. That doesn't speak to quality of participation, but we'll get a number. We do work diligently with tribes and with the community or the state-based review team to help build collaboration or to help build autonomy for a tribal-specific fatality review. We can go either way. So that's a we'll get back to you. Your second question on focusing on strengths, we agree with you completely. And in fact, 2 years ago, modified our data form to capture not only risk factors, but also protective factors. And there still needs to be a lot of education around that because, you know, the thinking is typically a child died, nothing could have gone right. But there are protective factors to be found in there. So again, it's another, we're started, we're not there all the way. And we get to, we're gonna take a little 6-week break, but then we'll be right into version 6.1 where we love this feedback because we wanna make every version a little bit better.
And to the degree you can be informed about what specific to American Indian, Alaska Native, Indigenous peoples' strengths, so that how you decide what questions are asked can capture that. And I go back to Ed's original comment that if we capture those strengths for this group of essential folks, it could also be informative about extending those strengths in other populations. So ask before you change, and an opportunity for taking the expert input that Shira Rutman talks about and bringing and informing what our surveillance and case review systems can have. And that would go to Title V performance measures as well, so that there's an alignment that begins to happen.
Yeah, thank you so much, Magda. Those are great points and an excellent conversation. So I want to thank all of our panelists. We are at time. Please continue to enter your comments in the chat and refer to them. There's excellent points within them. And so again, thank you all for a really excellent conversation and a jumping point for our recommendations we're going to work on for tomorrow. So Dr. Ellinger.
Dr. Collier, thank you for moderating that. Thank you for the presenters. This was a great session. I particularly appreciate that Diane and Maureen and Abby actually changed their schedule. I know they have a big meeting coming up and had to sort of fit this in. So I really appreciate the effort to make that happen. And certainly, Shira, you provided some essential information. It was really helpful. So this really a nice mix of data and story and perspective that will really be helpful to us. And this is one of those issues that it'd be public health malpractice not to talk about SIDS and SUID when we're talking about First Nations moms and babies. So this helps us with that kind of information. So thank you very, very much. So now we're going to move on to getting a federal update. And in the agenda, it says Lee Wilson. I'm not sure, Lee, if you're going to do it or if you're going to bring in the secretary to do it, or,
I am not going to bring in the secretary. When it comes to federal updates, my understanding was that we were going to do a bit of a round robin with the various staff, ex officio members who may want to provide a little bit of an update on the work that they're doing. I have some updated notes from those activities that are going on within HRSA, in particular the Maternal and Child Health Bureau. So let me just jump in here. It has been a busy few months. And I will provide a little bit of an opportunity when I pause for Dr. Warren to give updates on our involvement and engagement at the department level with the formula shortage issues. But first, just on a program operations standpoint, wanted to let you know that our maternal, infant, and early childhood home visiting program, Mthp awards and state maternal health innovation awards have gone out. The announcements for those, HRSA announced approximately $16 million to strengthen the Mthp programs through 7 awards supporting 8 different states. These awards will advance data and technology innovations to support positive maternal and child health outcomes, both in states and communities, and will focus on addressing health disparities. We had announced the availability of $9 million through the State Maternal Health Innovation and Data Capacity Program to expand the State Maternal Health Innovations Program and reach additional states. This program supports state-level development and implementation of proven strategies to improve maternal health and to address maternal health disparities. The competition closed on the 13th yesterday. We received a number of applications and we'll be reviewing those applications for making awards by the end of this fiscal year. Additionally, HRSA is pleased to announce that on May 6th, we put out the launch of the Maternal Mental Health Hotline, which is a new confidential toll-free hotline for expecting and new moms experiencing mental health challenges. We had received an initial $3 million investment for this fiscal year to launch the hotline, and it was launched on Mother's Day on May 8th. Counselors are available 24/7 to provide mental health support nationwide. As I said, it's 24/7, free, confidential, before, during, and after pregnancy. And callers have a phone or text access to professional counselors, real-time support and information, response within a few minutes, 24 hours a day, 7 days a week. There are resources available as well, referrals to local and telehealth providers and support groups. It is a culturally sensitive support in Spanish and I believe 60 other languages for interpretation services. As I said, yes, counselors speak both English and Spanish. We are developing materials that will go out alongside the hotline so that there are call numbers available at lots of different sites. Also for individuals to have, we're exploring various options, but like a magnet for your refrigerator as a reminder of the number, those sorts of things. And we're making contacts with our grant providers and other organizations to be able to have on-hand referral materials. So we're very excited about the hotline. There's been a lot of attention on this, and we have, just for your information, it has not been broadly launched everywhere in all of the social media because it is a new hotline and because we were developing the system, going through all the security measures as a federal agency trying to do this. We have been incremental or phased in our approach to doing this because we want it to launch and to be good. We're very pleased with the very short period of wait times, much lower than industry standards, as we are ramping up this hotline for services to others. I also want to mention that the agencies within the department have issued a joint letter on May 25th to states, tribes, and jurisdictions, encouraging them to prioritize and maximize their efforts to strengthen children's mental health and well-being. The letter was signed by HRSA, SAMHSA, CMS, CDC, ACF, and ACL, and it outlines HHS's plans to support and facilitate state-level coordination across federal funding streams to advance and expand mental health services for children. We can, if there is further interest in this, we can upload some additional information about the programs that are engaging in the partnership, and we can provide that to you if you like. I also want to mention that we have been working with our Healthy Start program to continue our efforts in the area of supporting doulas. And we had announced a competition again for supplements to the Healthy Start programs to provide community-based doula services through our grantees. These will be women during the serving women during the periods of pregnancy, birth, and 3 months following their delivery. Award funding will go to cover the training and the services that they provide, with a special focus on trying to encourage doulas as a profession and something that is supported as a profession by the Healthy Starts. Granted, the Healthy Starts can propose how they would like to engage doulas, whether that be through contract or on staff, but we like the idea that we are promoting this as a reasonable profession that is being supported at the community level. Also, we have been running a competition for our Catalyst program for infant health. The application period closed on September 26th, and this new program will support the implementation of existing action plans that apply data-driven policy and innovation strategies to reduce infant mortality disparities in specific counties and jurisdictions. This program aligns very specifically with the message that Dr. Warren shared about his vision for addressing infant health equity and trying to reduce the number of infant deaths in communities that are experiencing disparities, so that we can achieve or move more deliberately towards equity across the races in our infant health outcomes. Finally, I just want to give you an update that the Women's Preventive Services Initiative has kicked off its 2022 year. They are meeting currently to review diabetes during pregnancy and postpartum, to update those guidelines for this year. The committee has been meeting to deliberate on the evidence reviews. We also have a rolling open period for individuals to submit recommendations for consideration for other guidelines to be considered on different preventive health services and screenings that can be provided. That's all I've got for now. I'll stop, and Dr. Warren, if you want to give an update on formula, that would be helpful.
Thank you, Lee. And the timing is perfect. And in about 5 minutes, I've got to hop on a formula call. So as many of you have been seeing for a while now, there are conversations happening around the shortages of infant formula. There had been some shortages throughout the pandemic due to supply chain issues. And then with the closure of one plant in North America, really exacerbating that. Across a number of types of formula, particularly for specialty and metabolic formulas. There has been a cross-government group that has been coming together very regularly. There are actually multiple groups that are meeting on this. The one we're a part of is a cross-government group that's got engagement from the White House, multiple parts of HHS, the Office of the Secretary, FDA, the Assistant Secretary for Preparedness and Response, as well as us here at HRSA, and certainly our colleagues at USDA who are involved with the Special Supplemental Nutrition Program for Women, Infants, and Children, or WIC. A number of things you likely have seen in the media, the effort to bring formula into the United States, Operation Fly Formula, and I will paste a link to the latest release. Those shipments or flights continue bringing in formula that has been vetted through FDA from other countries that will then be available through a variety of outlets in the United States. There's also been the invoking of the Defense Production Act to make sure there aren't any barriers to be able to get the supplies that are needed for formula manufacture in the United States. A few very specific things that we have been involved in helping with. The department launched a website that has information for families as well as providers, and I will put that link in the chat. That has been updated several times, and we've been involved through MCHB with that. We've also been involved in connecting with our grantees. So as you all know, we've got a number of grantees in a variety of settings, everything from state block grants, who are hearing from their partners, from family organizations, from providers, from community service organizations with insights. But we also fund things like the regional genetics networks, and those grantees work very closely with families who may have infants or children or adolescents who may need those specialty and metabolic formulas. So we've been gathering that information and making sure that's relayed. So if there are particular challenges, that we're sharing that information back up. We did some listening sessions at the AMCHIP conference. Laura Kavanaugh, our deputy, and I always meet with all the states at the AMCHIP conference. We've continued to do that even virtually to be able to understand what are the challenges. They're not the same across all the states. And for example, we were particularly interested in hearing from the freely associated states and territories as well, and understanding are there differences there. So those sessions were helpful. We in MCHB have issued some messaging a few times now for our grantees with information that they can share with families. Also information for providers, particularly providers who need to access specialty formulas, and resources to do that directly from manufacturers. And then lastly, I'll just say we're participating in a number of public-facing educational webinars. So the Assistant Secretary, Admiral Levine, did one for the Moms Rising group last week. We're participating in one tomorrow for a parent advocacy organization, on Thursday for the National Association of Social Workers, and then on Friday with the Tribal Child Welfare Group. So really trying to make sure we're engaging with partners across the country on this issue. Certainly, if you all have insights or things that you're hearing, please share those up through the committee staff, and we will make sure that gets relayed. Thank you, Lee.
Thank you, Dr. Warren. Just Magda wanted to let you know that Ann Leach will be dropping in, if she hasn't yet, to the box, the response to your question about the recipients of the awards. I also see that our friends from CDC, from OMH, I'm not sure if NIH is on the line as well, but wanted to give them an opportunity. Cheryl, welcome to this committee meeting. Cheryl Crollinger at CDC is now the representative of the Division of Reproductive Health. Big shoes to fill after Wanda Barfield's departure, but Charlene is up to the task. So I'll let Charlene and any other agency representatives provide their updates. Thank you.
Thanks so much, Lee, and good morning, good afternoon again to folks. I'd like to thank the chair of the committee, Dr. Ellinger, for requesting this update to provide additional information on activities relevant to the presentations and panels provided today and tomorrow. So I'd like to start with some updates from the Division of Reproductive Health at CDC. In partnership with the Office of Minority Health, CDC's Division of Reproductive Health is developing a segment of the Hear Her campaign, specifically focused on reaching and serving American Indian and Alaska Native women and their communities. In January of this year, the National Indian Health Board hosted a discussion session on Hear Her messaging. The meeting was attended by over 300 tribal health practitioners, tribal health directors, and others who serve American Indian and Alaska Native pregnant and postpartum women. The feedback provided was critical for Hear Her messaging that's currently in production and will be released later this year. In fiscal year 2021, CDC funded 30